Welcome to the Resus Room podcast.
5, 4, 3, 2, 1, fire!
So hi and welcome back to the Resus Room podcast. I'm Simon Lang.
And I'm Rob Fenwick.
And this is February 2020's Papers of the Month.
That's right, Langers. We've got troponins, we've got comas, and we've got the SET trial looking at the cessation of seizures with different secondary medications. This is going to be a belter.
Yeah, it should be good, actually. Well, we've really let you down if it's not. But this follows on really nicely, actually, from our previous Roadside to Resus episode on seizures. So that last paper that we'll be looking at is really interesting to see whether or not our conclusions about which second-line anti-epileptics are really the ones that we should be using. Before we get into the podcast, a big thanks to the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine. They're our partners with us on this podcast and are a free open access journal publishing papers on all the sorts of topics that we talk about here. So without further ado, let's crack on to paper number 1. Okay, so on to troponin testing in an undifferentiated and elderly population. Always get a little bit worried when we say elderly population and realise that each year as it creeps on, we're getting into that cohort.
Are we in this cohort yet? I don't know if we are. We might be.
Well, no, but we're more than halfway there, which is slightly worrying. So I think if you've listened to a few of our podcast episodes before, we're quite interested in the idea of over-testing. And when I say interested in it, as in interested in not over-testing.
No, yeah. I'm a massive fan of over-testing.
But the problem being, as practice evolves, a lot of our practice is defensive and we're worried about missing things. And this paper is really interesting because it focuses on how we're using troponin testing and the benefits to that and possibly some of the risks associated with it. So we can all imagine that patient coming into our emergency department with an undifferentiated presentation and somebody, that might be somebody that's seen the patient before, so maybe one of the triage nurses, maybe somebody in rapid assessment, or maybe ourselves, send a troponin off to see whether or not this could be a cardiac event, even though they're not necessarily presenting with chest pain. And that's the sort of thing we're looking at here. Published in Academic Emergency Medicine, the lead author is Alfred Wang, and the title of the paper, Troponin Testing and Coronary Syndrome in Geriatric Patients with Non-Specific Complaints. Are we over-testing? Right, so a little bit about this paper. So it's a retrospective study only performed in one centre, and that centre is in the US at an academic trauma centre. So what they looked at is patients who are at least 65 years old coming to the ED with non-specific complaints who, as we've said, we can really easily imagine they've had a troponin sent. And the researchers predefined the sorts of triage complaints that they were interested in this non-specific presentation. So things like weakness, dizziness, fatigue, lethargy, altered mental status, etc., etc. And it's worth having a look at the paper, obviously, and then seeing a bit more about those inclusion criteria. Once they got that group of patients, they then excluded those who the attending clinician went on to categorise the chief complaint as any focal pain or injury complaint, shortness of breath, vomiting, diaphoresis, syncope, and a few others. And importantly, they excluded those with a temperature of 38 degrees C or more. So once they whittled it down to this group, they're then looking to see which of these patients with these non-specific complaints, which you've got more of an idea of now, went on to have troponins sent. Now, during this time frame, 2 different troponin assays were actually used. One which was a troponin I point-of-care assay, and another which was a troponin I 4th generation. They've got slightly different cutoffs for what is a normal troponin result during this. So we're looking at slightly different troponin testing throughout this period. They're then comparing this to who's being labelled as having acute coronary syndrome, and they use some guidelines for this, which were the AHA guidelines, which includes things like coronary revascularization, anatomic tests which show a blockage, positive stress test or echo, and a troponin rise. And they then removed type 2 myocardial infarctions. Then they did a chart review and they reviewed the next 30 days of that patient's journey in that hospital to see a certain number of things. What proportion of patients had the troponin sent, as we've said? What proportion of these had an elevated troponin, defined as the hospital's cutoff? what proportion of patients had an acute coronary syndrome diagnosed within that 30 days, the utility of troponin testing to diagnose or rule out acute coronary syndrome, and the frequency of other causes of a raised troponin. So they looked at quite a number of things in this one study.
Yeah, and I think those are important points, Simon, actually, because these are questions that are important, and I've certainly been there many times where I've had to act on the results of a test that was sent not by me. And this is something that you will come across in your practice, and actually the relevance of that to the patient that you're seeing at the time is hugely important. So these questions that they're asking, whilst it might seem a little bit strange from the title of the paper, are actually perfectly relevant potentially practice guiding results. So what sort of things did they find then, mate?
Okay, so they've got over 400 patient encounters that were identified meeting the criteria that we've already talked about. And the first thing to say is that positive troponins were found in 82 patients, which is a fifth of this patient cohort coming through. So to put that into context, these are patients with non-specific complaints. 20% of them in this older population with these non-specific complaints have got a raised troponin. Now, 5 of these patients are then deemed to have an acute coronary syndrome. So we go from 82, which are positive, down to 5, which have an acute coronary syndrome. Now, again, it describes really well in this paper the journey of these 5 patients that had acute coronary syndrome. But if you're looking at who went on to have a specific cardiac intervention via cardiac catheterization, there was only 1 patient that went for that was found to have diffuse coronary disease and wasn't amenable to intervention.
Okay, interesting. So 20% of the overall population had a rise in their troponin, but only actually essentially just over 1% were deemed to have ACS. But of that 1%, we're talking so in the region of 0.25% actually had some form of coronary artery disease when they had their vessels looked at. Is that a reasonable summary?
Excellent maths for this time in the morning, Rob.
Thank you. It could be the evening. Who knows? That's the beauty of podcasting.
I can see the abacus moving across just as you're working it out. It's fantastic work.
It's a silent abacus. I got it for Christmas.
Now, there are loads more statistics in this paper that you can go and have a look at. And there is actually quite a lot to take out of this paper. But the bottom line is, from this single centre study, which has got some limitations, hasn't it? It's retrospective. As we said, it's single centre. There's different troponins being used. There's some incorporation bias that's worked into this trial as well. But what we're saying is there's a 20% chance in this cohort that if you send a troponin and you're not really expecting it to be acute coronary syndrome, that it's going to come back as positive. And of that 400 patients, 5 of them are going to turn out to have ACS, as defined by this study, and 1 of them is going to go for cardiac catheterization. Some of them might have had their medications altered. But I think what's really interesting is to have a think about what you would do if this was your institution and how you might interpret this data into your practice. So, Rob, does this make you think any differently about testing, whether or not you want to carry on doing it the same way, whether or not you want to increase it, or whether or not you want to decrease it?
Well, so that's a good question. Put it this way. I don't think troponin testing, as the title says, in geriatric patients with non-specific complaints is a great way forward. I don't think that's going to be something that I'm going to be incorporating into my practice, which I think you and I will probably both be in agreement on. But that being said, whilst I don't think that's a good idea, it is interesting that, there is a mortality bump in those patients that have a positive troponin, even when they don't have an acute coronary syndrome underlying it. So, you could see it that it is a marker of illness and potentially a marker of poor outcomes. But in the UK, at least, we're not set up to think of troponins as being markers of mortality, are we? We're set up to think of troponins being as, let's get that patient comfortably on that ACS pathway, or where they're going to be go for PPCI, etc., etc., etc. So it's not used in that context, and it shouldn't be either, is my way of thinking about it. But as I said earlier, there are situations where you will be left with a test that you didn't order and you will have to act upon that. And I think that, it comes back to how likely you think this patient is to have had an acute coronary syndrome in the first place. And, I think a good history clinical examination and looking for other potential causes of their symptoms are the things that you have to do. And that's exactly what these authors did, isn't it? You know, they excluded those patients that had, like, say, temperatures of more than 38. So you need to go looking for other stuff. But if you're left with that result, it does put you in a pickle. But I don't think we necessarily need to jump on it and say this is an acute coronary syndrome just based on the fact they've had a raise in their troponin. There's many, many other causes. And, you know, let's not forget that testing and management of ACS is also associated with side effects. So, you know, 1 in 250, I think it is, you know, coronary interventions go awry. So, yeah, for me, I think you need to be very careful with your testing strategy. And if left with a result that you didn't necessarily want, you just have to go looking to see whether it's actually relevant.
No, I think that's a really good stance to take on it, actually. And I think what it also highlights is that it can feel like it's the right thing to do to send as many tests as possible early on to try and really rule out what's going on for these patients. But having that conversation with the patient beforehand, so let's say that these figures are reasonably transferable to the cohort that we see in our emergency department, which the honest answer is we don't know, but this is really useful information to inform it. If you said to a patient, well, you know, your history doesn't really fit with this being an acute coronary syndrome. It doesn't look like it's something to do with your heart. However, if we send off this test, there's a 20% chance that it will come back as positive, and that means more investigation. There's a 1% chance that it's going to come back and it might indicate something from your heart. But from this study, it looks like there's about a 1 in 400 chance that you're then going to go on to have a catheterization if you're one of those patients that's appropriate to have that. And I mean, when you start to say that out loud, it almost seems like a ridiculous thing to send the test off, doesn't it?
Yes, it does. Well, but then again, you know, it seems it's so different to how we practice, I think, in the UK, in that we wouldn't consider randomly chucking a troponin onto a non-specific complaint, really, in a geriatric population.
Really?
Well, so I wouldn't. I don't know. I'm speaking for myself here. You know, I do you think that that's widespread practice? Just chuck a troponin in?
So I think on every shift in every emergency department, and this is a pretty sweeping statement throughout the UK, this will happen.
Okay. All right. Well, interesting. Okay. Fair enough.
I'm not saying that's the right thing to do, and I'm certainly not saying it's what I'm aiming to do, but I think that when systems are under such pressure, I think that the first person that sees that patient, what they want to do is they're trying to anticipate what's going to happen down the line. Is anyone going to want a troponin? And they haven't got a lot of headspace or time, more to the point, to be able to think in more depth than that. And then from that point, this just cascades. And the resource utilisation and the other things that come as a result of that testing, which is being done in a great way, I think happens really frequently.
Interesting. Okay, well, there you go.
Yeah, no, and I think we would love to hear what you guys listening think about this, whether or not that's something that you encounter really frequently, or whether or not I've just got a ridiculously skewed view of testing in the UK.
No, it would be interesting. It would genuinely be very interesting just to see, because I might be ridiculously skewed in the other direction, mightn't I? You know,
I think so.
All right, let's agree it's somewhere in the middle.
Get on that fence.
That's right. Get splinters in your bum from sitting on that fence.
Excellent. Well, enough troponin testing in every way. Let's move on to paper number 2.
All right, so paper 2, let's talk about coma. So, coma of unknown etiology is the term
that's never going to be a hit.
It is in there, Christmas number 1. Coma of unknown etiology is the term used to describe an acute impairment of consciousness that is not caused by either traumatic brain injury or cardiac arrest. So, Simon, I think you've probably seen a few of these alerted to Resus in your many years of medicine, have you not?
Yes, I think I have, Rob. I think that's a fair statement.
Good. Well, let's just say I have as well, so that's perfect. Something we can agree on. Now, the underlying pathology for this can be broadly split into 2 categories, so neurological complaints and those that are extracranial and diffusely affect the brain structures, so medical complaints. Now, the important bit with this is that both of those, so neurological and the medical side of things, both include a number of time-sensitive conditions, but currently, there is a lack of a widely accepted algorithm for the initial management of this, well, coma of unknown etiology, I guess. So whilst we can all reel off this massive list of potential causes, well, I probably could, not sure you
Don't
could.
make me.
Hypoglycemia. Yeah, I know. We won't go there, but there's probably a big list. There really is a lack of data out there on the frequencies of the pathologies that we see in real patients. So whilst there's these lists and textbooks, actually what actually exists out there in clinical practice, there isn't a huge lot of examination or a lot of scientific study of. So this paper gives us a little bit of information around that and is some initial work to examine the most common causes, which hopefully might give us some rationale to guide our management. So, the paper title, Causes of Brain Dysfunction in Acute Coma, a cohort study of 1,027 patients in the emergency department. And this is by Wolf Schmidt and was published in the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine at the end of last year. So what did they actually do? Well, they enrolled consecutive patients at a tertiary centre in Berlin, so in Germany. They receive about 70,000 patients per year there, and this was running from 2013 to 2017, and they only recruited those with a coma of unknown etiology. So the level of consciousness was determined by assessing the ability of the patient to communicate either verbally, by eye, by head, or by limb movements. Now, interestingly, they didn't use a GCS score in the initial definition because of inter-rater reliability between the scores, which is something we've covered before. Now, all of these patients were examined by either a paramedic, emergency physician, or a neurologist, and their conscious level was initially evaluated, as we said, in the ED using those terms, and that entered them into the study, but then was evaluated using serial GCS scores, both before and on admission to the ED. So as we've said, there was some paramedic involvement in this, so this was pre-hospital as well as in hospital. Now, all patients received examination, obviously, including a full neuro exam. They received ECG, blood gas, toxicology, cranial, intracranial imaging, and CSF testing as appropriate. So how did they actually work out what was the cause of their coma? Well, the authors of the paper reviewed each patient's tests and their records to obtain what they felt to be the cause of it. Now, in this study, so they had 1,027 patients over this 4-year period. 854 patients had a coma which persisted until all emergency diagnoses were completed. Now, the median GCS was 5 out of 15, so pretty low by all accounts, and the median age was 65. Now, for those that had transient coma on scene that had actually improved by the time they got to the ED, the GCS was just 8, and in hospital it was 14. So importantly, those ones that did improve didn't often get back to complete baseline. They were often confused or had a GCS of 14, so were dropping 1 point. But anyway, enough of that. Let's get on with the results. So we've said that 854 patients in this study had a coma. So what were the sort of pathologies that we're suffering from? So 39% of those suffered an acute central nervous system event. So acute primary brain lesions accounted for 39. So that was proof of either acute structural or inflammatory brain damage on imaging or CSF testing. A further 25% of that 850 had primary brain pathologies without acute lesions, so 39% with brain lesions, 25% without, and the remaining 36% had pathologies that affected the brain secondarily, e.g. aortic dissection, etc., etc. Importantly with this, the in-hospital mortality associated with this persistent coma amounted to a whopping 25%. So I'll just go over that once more. Acute brain lesions, 40%. Primary brain pathologies without acute lesions, a quarter, and a third had secondary pathologies that affected the brain. So that is pretty stunning stuff. Okay, Simon.
Oh, not as stunning as how much you're relying on our mathematic ability from going to percentages to fractions. Wow.
Yeah, I use them interchangeably. They're essentially the same. It's fine.
Phew.
So that's pretty interesting though, isn't it, Simon? So actually, when you're looking at these patients that have these presentations of a coma where you haven't got a clear cause for them, these are pretty astounding results, aren't they, to sort of guide what you're going to be looking for in terms of causes. So what were your thoughts on it from a clinician perspective working in the UK?
Again, we're looking here, aren't we, at a single centre study, and this isn't in the UK, so we can't necessarily transfer the exact numbers that we've got in front of us to the patient cohorts that are presenting to our emergency departments. But what it does is it gives you a really good feel for how much you need to be concentrating on this being a primary brain problem as opposed to it being secondary or it being another pathology associated with it. So I think this is really useful when we're trying to think of our differential sieve of what this could be. This gives you a really good structure, doesn't it? And there are certain things which you can work out really quickly, things like that hypoglycemia, which take a very limited amount of investigation. You can get really rapidly and you can make a big difference to things. I think understandably, we like to see imaging of people that are unconscious, but actually we've now got much more of an idea of what the likelihood is in this cohort that there's going to be something that's going to show up on that neuroimaging, whatever modality that might take.
So that would be 4 out of 10 patients. So 40% would have positive imaging if this study was to be believed. So would that?
Well, you said 39% earlier, so I don't want to critique
You're
this
right.
too much.
You're right. I'm sorry. Yeah, I stand corrected. But is that pushing you more towards imaging or less towards imaging in terms of your normal strategy, or doesn't affect it?
We wouldn't have picked the paper if it didn't affect us. So I think it certainly isn't going to take away the importance of neuroimaging. It's going to give an appropriate weight to how much we need to do that. And obviously there are huge variances in how people present, and there'll be certain clues that will point us towards the right diagnosis rather than just our traditional diagnostic testing. The history is where the answer is, and the examination and the testing supports that. But I think this is really important to view that patient as a whole and to make sure that you're considering a huge breadth of differentials, which might not just be in their head.
Yeah, definitely. I was quite surprised to see that it was as high as 40%, I must say, the positive neuroimaging finding or structural damage. But at the same time, that does sort of reassure me slightly that, a low threshold to image them is probably the right thing to do. But if you read into the detail of the paper, there's a couple of other bits which are quite interesting in themselves. So like these patients that had a return to almost baseline by the time they arrived in the ED. So you remember I mentioned about the pre-hospital coma that was at a GCS median of about 8, and then by the time they arrived in the ED had a GCS of 14. Well, actually the structural brain lesions in that cohort was 25% as well, so a quarter of those had some abnormal findings, which, I was really surprised by that, to be honest with you. And historically they wouldn't have been necessarily the group that I'd have thought about imaging. I'd have probably thought about watching, waiting, and sort of seeing what other diagnoses you can find really on them. But that's worth bearing in mind.
It definitely is, and I think it highlights the importance, again, of making sure you've been through that pre-hospital information that's been picked up by our colleagues, because it's really easy, isn't it, just to focus on what we've got in front of us, but the presentation of that patient over a period of time is really important, isn't it? And it must be pretty galling, I think, for all that hard work that goes into those pre-hospital records, that then at times come into the emergency department, there's a delay for whatever reason, may that be electronic records or it just reaching you, or you don't put due care and attention into reading it. And there are some real gems in there that we really need to focus on and pick up.
Yeah, absolutely. I think it goes further onto the system as well. So, when you refer on to a specialty, they need to also be considering what it was that the emergency department found on their examination, et cetera, et cetera. So it's a continuity of care, isn't it? It's not just dealing with what you've got at the time. I guess the only other thing that is probably worth mentioning that was in the paper was a little bit of a discussion about keeping an open mind and not stopping our diagnostic workup as soon as we come across a pathology that we think explains that coma. So the classic example of that being the intoxicated patient that is a minefield, and not just saying I've got a little whiff of diamond white on his breath, we can stop there and not do anything else for that patient. There is a healthy amount of respect that needs to be had for these patients across the board. So yeah, obviously don't need to image everyone, but at the same time don't let your own biases affect what you're doing with that patient, which I'm sure you wouldn't anyway.
For those that are listening that don't have the same class of palate as Rob, Diamond White is a relatively cheap and a highly alcoholic drink that he may or may not be drinking whilst we're recording this podcast.
I would describe it as potent. A potent beverage.
Yeah. Anyway, it doesn't refer to diamond white in the paper, and that's important to note.
It does not.
But no, a really interesting paper. And again, all of SJ Trem's papers are free and open access, so go and have a look at those and have a look and come to your own conclusions with that paper. So, on to our third and final paper then. So, as we mentioned, we've done a recent Roadside to Resus on seizures, and in that, we looked at the best medication for stopping seizures. Now, first line, we're looking at benzodiazepines, and then second line, we're looking at a variety of medications. And really recently, in the New England Journal of Medicine, there's been another paper that's come out on this topic. So it was entitled Randomised Trial of 3 Anticonvulsant Medications for Status Epilepticus. So this is the Established Status Epilepticus Treatment Trial, also known as ESIT. And the lead author of this paper is Jaideep Kapoor. So, what does it look at? Well, interestingly, this isn't just an adult study. This is joint adults and peds. So it was looking at ED patients aged 2 years and older that have been treated for a generalised convulsive seizure lasting more than 5 minutes. And as we've said, that is now commonly used as the definition for status epilepticus, treated with benzodiazepines and continued convulsive activity after the last benzodiazepine for at least 5 minutes. But importantly, no more than 30 minutes after that dose. Now, they specify in the paper the amounts of benzodiazepines that have to be given, so it's not just that they've had a benzodiazepine, but they've had a reasonable dose. And that could be diazepam, lorazepam, or midazolam. And if you want more details of that, go and have a look in the paper. So, you've got this cohort that basically are fitting, they've been treated, and it's not stopped within 5 minutes of this benzodiazepine. They then exclude patients that they believe the seizure is a result of a number of different things, including hypoglycemia, cardiac arrest, it being a post-synoxic seizure, pregnancy, and also in patients that have gone on to be intubated. Now, the intervention that they're making is with a randomised control trial. So this is a good study. And what they're being assigned to in a multiple number of centres is random allocation to either levetiracetam or Keppra. I'm quite pleased with that, actually. It's become an easier thing to say.
This is slick. There's no point shortening it to Keppra anymore, mate. Just say it as its full title. We've got this down.
I feel my PDP has been ticked by being able to say levetiracetam properly. This is
well
good.
Done. I'll do your DOPS.
Thank you. Phenytoin or valproate. So randomised to one of those 3 treatments. Rescue therapy could be given as deemed clinically appropriate by the attending team, which again is a good pragmatic way to run the study. So what they looked at, and this is really interesting, is the primary outcome of an absence of clinically apparent seizures and improving responsiveness at 60 minutes after the start of the trial drug.
Oh, 60 minutes, that's a fairly hefty time period. I think we were talking in time frames a little bit shorter on our seizure episodes, were we not?
Yeah, I think that is quite controversial, actually, and whether or not I'd be happy watching my patient to see whether or not they were still fitting at 60 minutes after I'd started phenytoin, Keppra or valproate. I mean, I think the answer to that is absolutely no, I wouldn't be happy, but that is the primary outcome that they've chosen. They predetermined that they were going to do interim analyses throughout the trial to see how the results were going and whether or not they should continue the trial. And they powered the study to identify the most effective treatment if the true difference of seizure termination rate were at 15%. So they're looking for quite a big difference here in the ability for these second-line agents to terminate seizures. So what you all want to know is, what was the outcome of the study? Well, there were 400 episodes studied in this RCT, and that was from 384 different patients enrolled. So there are a few that are coming in with more than one episode. And recruitment was ceased upon recommendation of the Safety and Monitoring Board after the trial met the predefined futility criteria during one of these interim analyses, because they found that there was a 1% chance of showing that one of these agents was the most or least effective treatment. The results that they did find during this time frame is that 87% of these patients had a final diagnosis of status epilepticus, with 10% of these being psychogenic in origin. Unblinding of these medications occurred in 46 of the 400 enrolments prior to 60 minutes. And probably the most important result is that the number of patients with the primary outcome of no seizure and improving conscious level at 60 minutes was 47% in the levetiracetam, 45% in the phenytoin, and 46% in the valproate. So all really similar numbers and all having confidence intervals of about 15 to 20%. Admission rates to ITU were similar. Phenytoin saw that 3% of patients had hypotension, which was a bit more than the other groups, and only Keppra saw a patient with an arrhythmia. So Rob, what do you think about this trial and the results of it in the context of our Roadside to Resus episode?
Well, I think it's a great study, and I mean, it's got a lot of hype around it on social media, and a number of the blog sites have covered this as well. So Pulm Crit and The Bottom Line have been onto this as well, and I think rightly so. It's interesting. I think obviously it is a little bit of a shame that it was stopped early, but if you're not going to get a result that's positive, then trials are costly, and actually to continue that for no benefit is not going to add anything to the evidence. So that's fair enough. I think obviously the take home point here is that of the 3 medications that are listed in there, which are the ones that we most commonly come across in practice, there's no difference in that seizure cessation rate at their predetermined time period of 60 minutes. So essentially it can be, from an efficacy point of view, there's no difference, so choose what you want. But it comes down to really, I think, the side effects, which in this group there weren't a huge amount of side effects actually in any of the medications, but you have to look at the side effects that are listed on the medications to work out which one you want to choose, which one's easier to administer, which one you can get in more quickly. And I think for me that would support levetiracetam, I think, based on what we talked about in our Roadside to Resus episode. So yeah, for me I think it supports that, but it's slightly concerning that you only had seizure cessation of 47% of the patients that received it. So you need to have a pretty low threshold, I think, for stepping things up. And I guess that's probably my take home.
There are 2 different things here, aren't there? There's the critical appraisal of the study, and then there's actually what this means for practice. So I think looking at what they were trying to find, a 15% difference in termination rate, that is pretty ambitious, and what that means is that if you're looking to find a bigger difference, that you're going to need a smaller number of patients. So you could argue that this is really underpowered for what's likely to be the difference in these medications. Also, the trouble with it not being a phenomenal amount of patient encounters, but obviously a huge amount of work, is that it won't really bring out some solid results on the difference of the side effects with these medications. And things like arrhythmias, if they're difficult to control or if they result in poor patient outcomes, I don't want to give a medication that 1 in 200 times is going to give an arrhythmia to one of my patients. That's not what I want to see. But again, I think looking at this study, it's really difficult to draw conclusions of that. However, we've got to be realistic, haven't we, about the amount of research that can be performed, the amount of money that's available. And I think, to me, and I've obviously got a bit of a bias, that this confirms what we'd concluded, I think, during that Roadside to Resus episode. And actually, these agents are safe. I don't use valproate, but I would use Keppra and I would use phenytoin. And I think it just confirms the fact that picking one of those 2 that I've got available to me is perfectly reasonable, and we can make a validated choice over giving either of them. And this study is useful in being able to help consolidate that as a conclusion.
It is, yeah. I agree with you. I think that this is one of those papers that it is really, really worth going and having a read of, because there are some elements of it that are not common in terms of UK practice. So, I mean, for example, the dose of Keppra that they used is fairly sporting, about 60 milligrams per kilogram, which is 4.5 grams for someone that's 75 kilograms. So the BNF states that the maximum dose that you give is 1.5 grams. We don't use anything like that dose in the UK. So actually what that means for your practice and what that might do for the results if you used a UK dose versus what they used is completely unknown. And, in the study, all of their medications were ready to be drawn up next to that patient's bedside. So there would have been hopefully minimal delays in calculations, drawing up, etc., which might not transpose well into the real world. So, I would thoroughly recommend going and having a read of this, and also having a wider read around the blogs and things, because it does throw up a few questions and a few things that you need to consider when making decisions about what your second line medication will be for status.
So that's it for February's Papers of the Month. So just to recap, we've covered 3 studies. We've had a look at troponin testing in the elderly population and got a bit more of an idea from that single centre study on the utility of troponin testing when someone comes in with an undifferentiated presentation, and might give you a bit more context to having a chat with the patient and with their families about the risks and benefit of further investigation with a troponin. We've had a look at a paper which has really nicely demonstrated the differential diagnoses for people coming in with a reduced level of consciousness. And then finally, we've had a look at a paper which shows that with 3 different second-line anti-epileptic drugs, that actually the likelihood of cessation at 60 minutes, which as we said is a huge period of time, is not very different in that study between levetiracetam, phenytoin and valproate. A big thanks to the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine, who really do make delivering this podcast to you for free, and this open access education, well, what we hope is educational, is there for you for free, and we really are grateful to them. They've got a fantastic open resource where you can go and check out any of their papers. If you want to know a bit more about critical appraisal, then go and have a look at our podcast online course, Critical Appraisal Lowdown, which we've got a link to on our website. And we will be back with another Roadside to Resus on stabbing for you in a couple of weeks' time. So take care of yourselves, and we will speak to you soon.
Speak to you soon.